guys. It's Steve.
Hi, Steve. This
Hi,
is Carlos.
Steve. Hi, Steve. It's Paul.
Hey, Paul.
Steve, thanks so much for joining on the conference call.
No problem.
My friend Carlos reviewed a couple things, and we had a long discussion, and he came up with some brilliant ideas as usual. Carlos, why don't you share your thoughts and see what Steve thinks of it, and see how we can move the process along.
Steve.
Carlos.
There are just certain indications that I don't think that there are any brilliant at all, but I am trying to how to get these studies to be more implemented. So I want to start a little bit on the second one, the Initial Idea Project 2 of yours, because I think that's the one that I think is more interesting, but also more problematic. Basically, I think that what you're trying to suggest here is a Sonic-like study using the different drugs in people with early disease compared to people with later disease. If I interpret it correctly.
Actually, it's not even Sonic. I mean, the problem is ever since 1998, when Remicade was approved, it's approved for moderate to severe disease not responding to stuff.
Yeah,
and,
I agree.
Every other drug has been approved with the same indication. And so what it's excluding is the people who would benefit the most, which is early disease. Because as you well know, those individuals, we're giving it to people who already have strictures and fistula. We need to give it to people before they do. And those individuals from the studies with Humira and with Cimzia and with vedolizumab now, all showed that the absolute response rates are better early in the disease than later. And it's just hard. We don't have when we try and prescribe them, the third parties say, no, they've got to fail therapies first. So
Steve,
I think that,
I agree with you.
Okay,
this is
sorry.
This has been bothering me for years, that the rheumatologists have been able to use, anti-TNFs compared to methotrexate as first-line therapy, and the gastroenterologists have not, the gastroenterology field has not conducted a similar study. Sonic, as
it's
you
actually
well said,
going to be worse with Stelara, because Stelara is a first-line drug for psoriasis, and we're going to have to wait for patients to fail everything, even though it's a very safe drug.
Yes, yeah. On top of that, you don't really know how well they do in these patients. The one thing that I go to the parallels in rheumatoid arthritis is that these people, the rheumatologists, had good predictors of which patients were going to progress before they even started methotrexate. They knew which patients are going to do worse and which ones are going to do better. They didn't give it to just randomly patients naive to treatment or anything like that. They had some ideas. And I think that Corey Siegel has recently done this predictor of which patients have a higher probability of getting worse. And I think that if you want to show in the study that giving biologics is better than giving, AZA or something like that, you need to pick patients that have a chance of doing worse than just a random patient. Otherwise, the sample size that you're going to need is going to be enormous to show differences. The second issue that I see here...
I'm not sure, Carlos, because, the first-line therapies outside of the TNFs really don't have much mucosal benefit. It's primarily symptomatic benefit.
Right, but then you need to have patients that have mucosal activity at the time of entry, not a history.
Oh, absolutely. That would be the criteria. Absolutely, they have to have mucosal disease.
So I think that some of these issues and some of the learnings from Vedo as well, and if you look at the TOFA paper that was published, from the phase 2, if they do not have markers of inflammation or if they do not have ulcerations at baseline, those patients should not be entering into the studies, naive or failures or whatever you want to call it.
Yeah.
So my point is that you have to be just slightly careful on the inclusion criteria beyond being naive to treatment. That's all that I'm saying here.
Yeah, no, I totally agree that they have to have evidence of mucosal activity. That goes without saying nowadays.
Yeah. The second issue is that if you do a study now, it's going to take a couple of years to get the results for that. And in a couple of years, at least one of the anti-TNFs is going to have a biosimilar. The cost is going to be probably, 1/5 of the cost of the treatments now. So it's going to
it will be higher, but I agree with you that there will be biosimilars, and it's tough to get the companies to do it. On the other hand, we might consider going to a biosimilar company.
That's what I was going to suggest to you, going to a biosimilar company.
I mean, these aren't small companies. I mean, you're now talking about Pfizer and Amgen are going to be the first two to have biosimilars for Remicade and Humira.
It's funny because when I was talking to Paul earlier, I said, this is the perfect study for a biosimilar company because you can beat everybody else by going first-line therapy and showing that you're going to be significantly more cost-effective than using the expensive new drugs for them. I mean, that's how they will position it because I don't know what difference you're going to find between Vedo, Etro, whatever new drugs, or Stelara, and an anti-TNF here. It may be that even if you find differences, they're not going to be overcome by the cost of treatment here.
Yes.
So, okay, perfect. Then we agree on everything. That was easy.
Well, you and I usually do end up agreeing, but
it's because I listen to you, Steve.
No, it's because I listen to you.
Oh, okay. Anyway, that is easy because then we have to figure out how to get this to make the biosimilar companies interested here. I don't know if you know, but my wife works in market access at Amgen. Did you know that?
No. I was just out there the week before last.
You were here at Amgen?
Yeah.
It's interesting.
I gave them a background on IBD. I spoke to all their medical science people. And then also, I was at the FDA for Celtrion for the biosimilar, and I'm helping Amgen with their application process.
It's interesting because if you just, as a company, you know that they decided not to pursue gastroenterology, even though the head of Access is a gastroenterologist.
No, I don't know that.
Yeah. They've discussed purposely not to pursue indication in gastroenterology. That's why their anti-IL-23, they gave it to AstraZeneca.
Uh-huh. No, I didn't know that.
Yeah. Pity we did not know this because I would have loved to see you when you came here. I would have invited you to lunch or dinner or something.
I did my usual in and out because, they've canceled a lot of they've stopped having a lot of the late afternoon flights back to Chicago. It's a bit of a pain.
Oh, well, anyway, I would have loved to see you. I would have stopped by just to say hello.
Okay.
It's in my neighborhood, and I would have introduced you to Suzanne because she's the...
that's the disappointment.
Yeah. Anyway, I'll try to find out through her what is the contact person in the biosimilar group there, because then I'll work and figure out something. I think your idea is very, very good, and if these people are smart, they should jump into something like that. Now, which is the other one you said? Because I think that Merck is not doing this, is it? Are they?
Yeah, Merck is actually partnered with Samsung, believe it or not. Samsung is making TVs and biologics.
And beer.
And beer.
Yeah, I think...
who else is doing it? Boehringer Ingelheim.
Ah, BI, okay. Boehringer, I think, also has an anti-IL-23, the same as Lilly.
They may. I've been helping them mostly with their biosimilar program, which is versus which is Humira, again, Humira-like.
Have you met Joseph Smolin? Because he's done a lot of that in rheumatology with the. Of
course, I've been at advisory meetings with him with several of these. I've been in a number of meetings with him.
I think I was even at one of the meetings with you and Joseph years ago. Yeah.
But even within the past year, we've been together. I think whether it was for Amgen or Pfizer, I'm not sure, because Pfizer was developing their own, and then once they purchased or merged with Hospira, which had the deal with Celltrion, they decided to just take on Celltrions.
Yeah. Yeah. Okay. I don't have contacts in Pfizer at all. That's been a total block for me to go there.
Well, they've expanded, into, they're a bit, they're overextended, so they've got, they bought Actavis, so they've got a mesalamine, they've got the old Azicol, Delzacol, then they've got, obviously they're doing tofacitinib, and now they've got the generic, the biosimilar, and they're also developing another JAK1 inhibitor possibly for Crohn's disease.
Okay.
So, they're all over the place, and they don't have the problem is they're siloed. So, their biosimilars do not talk with their conventionals that don't talk with their development. So, and when I was speaking with them at the FDA, the guy I was talking with said that they were actually thinking of, splitting up companies now and having different, companies within Pfizer. So I said, that's crazy from our standpoint.
It's interesting because
I said, don't send me 3 different reps. I said, just send me one medical person.
Yeah, most of the companies have silos that don't talk to each other. It's very frustrating, so I'm not surprised.
See.
Yeah. So, anyway,
just a question before we go on to the other one. How large a study do you see this being, Steve? How many patients and how many sites and do you think the patients are readily available?
Well, that's the hard part about this. So you've got to, in this, if we're going to go early, it's going to be if you're going to do a traditional development program, it's going to take a lot of sites to do it. So I don't think you're really looking to do a 1,000. You don't need a 1,000-patient trial. You're going to you don't even need a large trial for this if you pick predictable endpoints such as mucosal endpoints as well. I didn't answer your question. It depends on how we're going to do this, whether you're going to do this as a comparative study or not.
Right.
If you're going to do this as a traditional development, you need 100 different sites, but that's very impractical. So I would look at enrolling primarily new patients who don't have the complications at their baseline. And I don't know, we need to think this through, whether you're going to do this comparative or not, or what your comparator is going to be.
Right.
Do something like the Ferry Braidfeld did with BEST, where you randomize, but open label.
But BEST had a lot of patients in it.
Yeah, but this is a strategy study more than just a comparative.
I agree. I think we need to sit down and whip out the strategy.
Yeah. Okay. That makes sense.
Carlos, did you want to talk over the first study and reading the protocol and coming up with those different ideas you had?
Yeah. Yeah, I told you, Steve, in writing, I think that therapeutic drug monitoring now should be used primarily to pick the initial dosing of. I think that this thing for maintenance, there's been too many studies going on, and I'm afraid that by the time the study's finished, it's going to be not that exciting to the community. So I really think that trying to figure out how to use the current drugs more efficiently and trying to learn from the last couple of years is going to be much, much more important. So,
well, I agree with you, but there's the practical aspects of that is that even if you use calprotectin, unless you have a point of service exam, that's going to take the turnaround for the central labs for that is too long to make short-term adjustments.
Well, I think that the study cannot have short-term adjustments. I think that the point that they're saying is that from the study you will learn how long it may take it. When we did this hepatitis C study, we gave it for 4 weeks daily, not knowing if that was going to be ideal or not. And we from there were able to figure out, okay, if you're going to use interferon, this is how to do it. I think that the issue here is to look at the decline in either in CRP or how long CRP is normalized, or the decline in fecal calprotectin. Because if fecal calprotectin takes more than 8 weeks, to get below like 150, then changing from high dose to a standard dose when calprotectin is still elevated may not be the right thing to do. And we should be able to say if a patient starts at a very high level, you have to treat them more aggressively than if the patient starts at a low level. If you look at the paper you sent me from Bill, most of the patients that responded had low calprotectin to begin with. They didn't have high calprotectin.
Well, of course, because, it's easier to treat mild disease than more severe.
Correct. And it's the same thing that happens. They say a low HPI is a good predictor of response. Yeah, of course, because that's it's much easier to get a low HPI if you start with a low one.
Absolutely. It's it's easier to get to the first floor if you're on the second floor than if you're on the 9th floor.
I always joke, if you have a small headache, you take 1 Motrin. If you have a big headache, you take 3 Motrins. But if you have a small headache, Motrins isn't any better than 1 Motrin. So
right. I have the calprotectin. The practicality is it's possible to get a point of service exam, but it's a bit of a hassle to do that.
I know,
and why not, Carlos, do this with drug levels?
Oh, I think that you have to do drug levels as well.
Okay.
I think you have drug levels, CRP levels. I also want to do serum calprotectin and fecal, because if serum and fecal are equally good, then you don't need to do the fecal calprotectin afterwards.
Yeah, that would be a lot easier.
Correct. That is the most interesting thing to me, is that if you can do serum calprotectin instead of fecal, then it's I don't want to say home run, but
But I bet you, I sent you that link to the neutrophil marker.
Yeah.
The CD something 46.
Yes. No, you didn't send me a comment saying that was there, so I'm going to follow up on it.
Yeah, just Google that, because there's been subracugithason has been studying that. It's a marker that they've actually looked at to differentiate patients who have sepsis, and when they have sepsis, that marker is significant, and it basically, it's an inflammatory marker. And so that may all, I don't know what's easier to perform or not, but that may also be as good a surrogate or better than serum calprotectin.
Steve, I think that we should add some of these things, because this to me is a bit more of an exploratory to try to demonstrate, is this being done correctly or not? That is not going to be the definitive study, but it's going to be a
Sure.
way of doing it differently. Or this
Okay.
is the past test if things should be done differently. I will never forget how at UGW you said that 0 to 6, even though there's not much difference from 0-2 versus 0 to 6, you wanted to suppress as much as possible. So that's exactly the same theory, but we don't know if 0 to 6-10 is better than 0 to 6 and then every 8 weeks. And which patients should be getting it? Maybe as we say, if you are on the second floor, going to the first floor, 0 to 6 is enough. But if you're on the 10th floor, you need a hell of a lot more.
Mm-hmm. No, I think that that's certainly true. We've seen that exemplified in particular in the inpatients with ulcerative colitis, where we're often dosing within days a second dose.
Especially if they start with low albumin and you start in...
No,
in
exactly. Those are the patients. Low albumin, they're getting 10 mg per kg from the first dose, and then if their CRP bumps again within 3 days or 4 days, we'll give them another dose.
Yeah, I remember many years ago, I did these charts, I think if you've seen them, of antibodies, drug concentrations, and CRP, and it was in individual patients, it was fascinating is that CRP started to go up before concentrations start to go down and before you even detect antibodies. But that's on maintenance, not on induction. So okay, this is cool. Now, if you're interested in the starting, I can write a concept for you and you look at it. If you still want it as a maintenance, then we can work something out there.
All right. Well,
it's not a creative protocol.
Well, I will tell you, it may not be creative. Well, first of all, no one's done this proactively. Everything's done all that data is post hoc analyses, right?
Well,
just like what you did with what we did with the accent. That was looking back, but no one's done it prospectively. What we're trying to come up with is how to advise clinicians in a relatively simple manner to do the monitoring. So, there is no advice. How often should you do it and whatever. I think that from my observation, supported by some of this post hoc data, is the end of induction is a good predictor. So that's why we did that, and then we tried to make it simple by looking at midterm, after 6 months. The problem, of course, with trough is that you can't make an adjustment if you measure trough. But since the kinetics are so linear, that's why we said we could do a pre-trough level. But even the logistics of this are a pain in the ass. Then you've got to have a patient come in, get the thing 2 weeks in advance, get the drugs levels back, then make an adjustment. It's fairly labor intensive, but
Yeah, I mean, both studies are labor intensive.
Okay. Got it.
Well, we seem to agree on everything, so this is good.
Okay, good.
I'll talk to Paul separately, and then we'll follow up with you, Steve, and we'll see where we are.
Very good.
Thank you. This has been very helpful.
All right. You guys drive safely.
Thanks. Thanks, Steve.
Right.
Bye.
Ciao, Carlos.